Hey, thanks so much for the introduction. I am confident that my mother would be very proud of that. So give me just a second. Let me get my screen sharing and we'll get to rocking and rolling. So hopefully you all can see my screen.
Looks
So
great.
perfect. Thank you. Well, I don't necessarily need to introduce myself. That was done very nicely. What I want to talk about tonight, though, is going to be probably a topic that many of you see and sometimes brush off as sort of the so-called soft tissue lameness or a soft tissue injury. But I want to dive in a little bit and talk more about some of these front limb issues that are more soft tissue in nature. So here's a list of disclosures of some companies that I lecture, consult, and get research funding from. Note that I am a key opinion leader with Zomedica on the PulseVet side, and they are graciously sponsoring this webinar. However, with that being said, I do think that I'm going to be able to provide you with a scientifically sound, unbiased lecture for tonight that hopefully will be very practical for you to take back to work, even tomorrow when you see these patients and sort of have a new take on how you might approach them. So let's start with a little bit of thinking. I know many of you, depending on where you are in the world, are either finishing up your day or have finished up your day, but think about the last time you maybe saw a patient like this. So here we have a dog walking towards us. It's got a nice little head bob. And I think we would all agree that this dog likely has a front limb lameness. In particular, this dog, since the head is going down on the right front limb, the good old down on the sound, this dog has a left front limb lameness. So we've established that, but the big question is, what do we do? This is a skeletally mature dog. And so we have to think to ourselves, well, could this be the elbow? Could this be the shoulder? It could also be the carpus or the digits. But many a time, as we'll talk about with the history here, a lot of these dogs may be stiff and sore upon rising. They may have an intermittent lameness that gets worse after activity. And so when you start to ask yourself, is this the elbow or is this shoulder, or more commonly what we refer to as the shelbow? Could it be a elbow issue with a compensatory shoulder issue, or could it be a shoulder issue and an elbow issue? And I think, it's a very real thing to discuss, and sometimes we laugh when we talk about shelbow, but I do want to bring your attention to this radiograph because this is a beautiful radiograph of the left humerus. This is not a radiograph of the shoulder. This is not a radiograph of the elbow. So if we're going to try to make diagnostic recommendations of a particular portion of anatomy, we need to make sure that the radiographic beam is centered on that and that we get well-positioned orthogonal views. So we would not use this view to diagnose a shoulder issue or an elbow issue, because as that region of interest gets further away from the center of the beam, we start to lose detail, lose artifact there. So just kind of keep that in mind when we start thinking about some of these forelimb issues and we have to figure out what's going on, because we have to then ask ourselves, well, watching this dog walk, how do we know? Is it the toes? Is it the wrist? Is it the elbow? Is it the shoulder? Or is it some combination thereof? And even before we get to the aspect of imaging, we have to rely on our orthopedic examination. And we have to really kind of start training our thoughts a little bit differently on how we're going to approach those, because we need to ask ourselves, is there a reduction in range of motion of the elbow flexion or extension? I mean, sometimes it's very easy. Elbow doesn't move. I think we would all agree there's a reduction there. But sometimes it's a little bit more difficult to say, well, I think it's reduced, but I'm just not quite sure. But even before saying, is there a reduction on range of motion, let's ask ourselves, is there muscle spasm or tightness on flexion of the elbow? This is a huge red flag, especially in the skeletally immature dog, where we really want to be thinking about developmental elbow disease. Versus, is there pain on palpation of the medial aspect of the elbow? Again, dogs with developmental elbow disease. Usually a mature dog with well set in arthritic changes isn't going to be that painful on palpation of the medial part of the elbow. Is there normal range of motion in the shoulder? Is there pain on shoulder abduction? And you're like, whoa, what is shoulder abduction? Is there pain, spasm, discomfort on palpation of the medial shoulder? And well, how the heck do I check that? Is there pain, spasm, discomfort on palpation of the supraspinatus or the biceps? And it's like, wait a minute. I kind of know this term in the biceps, but you're throwing out a supraspinatus. I don't even really know where that inserts. I don't know where to palpate for that. And then, to check our biceps, can you complete a bicep stretch test? And to do that, you have to say, well, what in the world is a bicep stretch test? And so remember what we're not looking for here, especially with orthopedic soft tissue injuries. We're not looking for direct pain or crying out. We want to change our mindset to subtle signs of spasm, tension, resistance, reduction in range of motion. So if you take that limping dog and you run through range of motion very quickly, you're going to be like, well, I don't get anything. Take radiographs, completely normal. And you say, well, it's got a soft tissue injury. Okay, what are you going to do? NSAIDs and rest for 2 weeks. Dog's probably going to look great. Going to go back to activity. Probably going to come up lame again, because tissues don't heal in 2 weeks, first off. But if we slow down and we start looking for those subtleties, I think we're going to be much more successful in defining what's going on. And then do remember that with a front limb lameness, you can have other players in the game, especially from a neurologic standpoint. If you have a cervical lesion or a plexus lesion, that could also cause a front limb lameness that we can see. So we want to make sure that we don't just zoom in straight to orthopedic, but we try to take that differentiation of orthopedic versus neurologic into consideration. Sometimes that can be difficult. So what do I want us to get through this evening? Well, I want us to understand what a supraspinatus versus a biceps strain is. And I say strain in quotation marks because we're going to define that. Once we understand that, I want us to recognize how to diagnose a supraspinatus and biceps strain, and then what are some treatment options. And then lastly, I'm going to introduce the concept of medial shoulder syndrome, which is what's shown in this arthroscopic image here. And we're going to recognize how to diagnose and treat for medial shoulder syndrome. And so we got a lot to go through. We're going to move pretty quickly. So hold on to your hats and we'll get started, and then we'll take some questions at the end if you have any. So commonly when we talk about this aspect of soft tissue injury, we have to look at, well, what are we dealing with? I mean, are we dealing with a weekend warrior here? That's most of our companions. They sit around during the week. Owners feel bad. They try to make up for it on the weekends. And the problem here is that a lot of these tissues are not conditioned for prolonged rest and then aggressive activity. And so it is very common to see some of these shoulder injuries from a soft tissues perspective in our companions. But then we have our performance animals. These are our agility dogs, our fly ball, our dock diving dogs. This is an image I just put in today. I got this from a client of a dog that I treated several months ago who's back to competing in agility, and he just looks wonderful doing that. He's back doing what he wants to do. Versus what's a working canine, because these animals tend to be highly conditioned. Both our performance dogs and our working canines, they tend to be in good shape. They tend to have good body conditions. Sometimes they're not that great in terms of strength, but they tend to do some of the same things over and over and over. So we want to start thinking maybe repetitive strain type issues. But generally, soft tissue injuries have multiple failed attempts at resolution. They're lame after exercise restriction, and they're lame after stopping anti-inflammatories. So you exercise restrict them, you put them on anti-inflammatory, they look beautiful. They go back to activity, clinical signs come right back. And so our goal is then to take a step back and say, let's figure out what this injury is and move away from just saying it's a soft tissue injury. Because with diagnostics available to us, not just from fancy equipment, but also our hands and palpation, we can start to figure out exactly what injury is involved here. And this is a video of my practice manager's husband's dog. We're actually great buddies, depending on how you look at things. I mean, here he was having a good time going after me in the bite suit. Once I took that off, he got his ball and wanted to start playing again. But one of my pride and joys is working with our working canines. I just absolutely love it. So here's an example. This is called fly ball. This is like a big relay race. These dogs go over these jumps, they hit a box, they get a reward, a tennis ball, they go back. It's very high paced. And there's a lot of concussive type injuries that we can see, even though these dogs are well conditioned. Because if we slow that down and look at like when a dog's coming in to hit the box, they could certainly set themselves up for shoulder injuries, cervical injuries, carpal injuries, elbow injuries. And so we can teach them how to actually do this correctly. This is poorly done. They shouldn't be going head on. I mean, this is like going at 18 to 20 miles an hour and then hitting a brick wall head on. I mean, it's crazy. But if these dogs aren't trained appropriately, they can have injuries. Or if they're repetitively doing something, we can see repetitive injuries. Versus our working dogs, for example, they go through all sorts of different terrain and they have all sorts of crazy extremes on their bodies that can set themselves up for some of these soft tissue injuries. And so, I think it's very important to return to sport, but also to return to work, that we ultimately figure out what these are and that we get these guys handled correctly. And so if we talk about a supraspinatus tendinopathy, and so now I've changed words on you. I've thrown out this big word tendinopathy. What does that mean? Well, tendinopathy is essentially a generic term for tissues that don't exhibit the typical inflammatory response that are typically due to overactivity and repetitive stress over time that are difficult to get under control. So rarely, and many times you're still going to see the radiologist comment and say, well, there's a bicipital tenosynovitis. Rarely do we actually ever see a tenosynovitis. More commonly, these are either a supraspinatus tendinopathy or a bicipital tendinopathy. And that's important because it really explains why we may not fully resolve the issue with just NSAIDs alone. And so the supraspinatus originates on the supraspinatus fossa. It inserts on the greater tubercle of the humerus. It's for shoulder extension, but even during the stance phase, it's actually an active stabilizer of the shoulder throughout most of the stance phase. As opposed to our biceps, it originates on the supraglenoid tubercle. So it actually originates intra-articular. It emerges out of the joint and it inserts on both the radius and the ulna, which aids in elbow flexion. And it also provides some degree of stability during the stance phase as well. So, willy-nilly going in and just cutting the biceps can have some negative sequelae to it. And I think we need to be cautious of that. And so when we talk about a supraspinatus or biceps strain or tendinopathy, these are patients that present with a unilateral or sometimes a bilateral forelimb lameness. When you watch them walk, they may not always be lame. Sometimes they might be lame. But if you watch them walk from the side, you'll sometimes notice they have a shortened stride length. They're sometimes not reaching out as far or flexing as well, but they look a little short-strided. They tend to get worse after exercise. They may be able to do things. The owners are going to be like, yeah, he still wants to run and play. But afterwards, I notice he's really kind of paying the price for it. Or they'll be stiff and sore upon rising. And initially, they're responsive to anti-inflammatories, but then over time, they become non-responsive to anti-inflammatories and exercise restriction. And that's usually when I get to see them. They've been seen by the general veterinarian. They suspected a soft tissue injury. They rested them. They tried NSAIDs. They did good. They went back to activity. They came lame again. So they tried it again. They did well. They went back to activity. They became lame again. And we go back and forth. And eventually they come to me for a workup. Now, it was said back in the 1980s that for supraspinatus tendinopathies that Labradors and Rottweilers were predisposed. I don't think that's necessarily true anymore. We see that in a whole range of dogs. And so the first thing I would tell you is a front limb lameness in the dog is going to be the elbow until considered or proven otherwise. But in a skeletally mature dog, if the elbow radiographs show no evidence of elbow OA, then there's likely some degree of a shoulder tendinopathy. I mean, that's just how common these are. The problem is being a dog, you're going to have wear and tear on these tendons because the things that put the most stress on them are speeding up, slowing down, and twisting and turning, which is what dogs love to do. And so ultimately, what we don't know really is what's the difference between normal wear and tear versus pathologic and clinical signs. And with biceps strains, we may get a partial response traditionally to intra-articular steroids. Sometimes we would suspect there was a bicep strain and we would inject a steroid and then there was no change. And it was likely because that dog did not have a bicep strain. It was likely because that dog had a supraspinatus strain. And we actually find that dogs with supraspinatus strains occur more commonly than bicep strains. The problem is the supraspinatus is extra-articular. So an intra-articular injection isn't going to help that. And so we really don't know the pathogenesis. And so one of the theories, though, is that there's a lack of blood flow at the origin and insertion, meaning where the supraspinatus inserts on the greater tubercle and where the biceps originates off the supraglenoid tubercle, there is not very good blood flow. And so over time with repetitive trauma and micro trauma, this can result in changes to the tendon fiber arrangement, but we don't get those typical inflammatory changes. And because there's a poor blood flow, there's a poor and dysfunctional repair response, and it takes longer. And so then we start to see calcification, which indicates chronicity. And many a times the biceps actually is the secondary problem child because the supraspinatus gets inflamed or gets enlarged, and it only lives about 3 to 5 millimeters away from the biceps. And so as that enlargement encroaches onto the biceps, it'll secondarily cause a biceps tendinopathy. And so the problem here is if you have this incomplete healing response, then the mechanical properties change. You don't have as good of elasticity to the tissues, and the amount of stress it takes for those tissues to fail starts to decrease, which means that you can still have activity, but you're going to pay the price because at some point that elasticity of the tissues is going to start to create discomfort if there's an issue going on. And so some of the things we would be looking for is muscle symmetry. So measuring limb girth. We can do this in the front and the hind limbs. That's the image there on the right with the Taylor's tape. We can also look at comparing that to the contralateral limb. Just know that limb girth measurements of the front limb is not standardized. There's no publications on this. There is on the hind leg, but not the front leg. We can look at range of motion of the shoulder. Many a times it's not necessarily decreased. It might be tight or tense, but we can certainly measure through the use of goniometry, which is this image here on the left. It's not very hard to learn to do this. It might take you like, I don't know, 15 minutes to learn. But really what I want you to do is palpate the insertion of the greater tubercle and the origin of the biceps. And as you're running the limb through range of motion, we want to go into a deep shoulder flexion, looking for any spasm, looking for any tension. If the dog's panting, do they stop panting and hold their breath? Do they start licking their lips? Or as you move into a bicep stretch test, are you able to get there and complete that? Or is the dog jerking or pulling from you? And so, for example, this first video on the upper left, I'm going to be showing you a bicep stretch test. So we've got the shoulder in flexion, and I'm going to be looking at the greater tubercle to make sure there's no spasm, but to make sure I can actually go to a deep shoulder flexion, and the dog's fine with that. From there, what I'm going to do is I'm going to extend the elbow while the shoulder is flexed, and that's going to then check my biceps. In a normal biceps, I can almost get the elbow extended and hold it. And that's what this video here looks like. I can get there and I can hold it. And notice this dog isn't jerking, isn't pulling, isn't uncomfortable. But we do need to differentiate a biceps tendinopathy versus a biceps tear. In a biceps tendinopathy, I'm not going to be able to complete that bicep stretch test. What's going to happen is as I'm trying to get the bicep stretch test, the dog's going to be jerking or pulling. It's going to pull away. It's not going to let me complete that. Versus a biceps tear is going to be like this second video where there's what's called a loss of infill, where I can just kind of keep going and going and going. And it isn't until we get really far that the dog starts to get uncomfortable. This is more indicative of a biceps tear. So we can differentiate a little bit between a biceps strain and a biceps tear. We can also use other diagnostics. Radiographs can sometimes be helpful, but again, we're dealing with more soft tissue things. So we can take this sort of skyline view to see if we have some changes in the bicipital groove. In about 12% of cases, you might see some calcification like this image here on the right. However, I can't say, is this calcification within the supraspinatus or is this calcification within the biceps based on this location? But the calcification is typically not causing pain. The calcification is the red flag saying that there's chronicity going on here. There's other things that can be used, such as an MRI. It certainly can be helpful in cases we can diagnose supraspinatus tendinopathies. It does require anesthesia. It's a little bit expensive, so it's hard to follow up in the future and say, well, let's re-MRI. But it's also debatable because radiologists sometimes have trouble deciding on what's a true supraspinatus versus not. And the reason I bring this up is Dr. Pounder at the Hospital for Special Surgery in Manhattan published a study in 2018 that found that the normal supraspinatus has what's called a trilaminar appearance, which means there's these two outer thin hypoindense margins with a central hyperintense layer. And for years and years and years, dogs were getting diagnosed with supraspinatus strains based on this hyperintensity on the radiographs, only to find that that's completely normal. And so we have to be very cautious when we're diagnosing these on MRI. And then musculoskeletal ultrasound is something that's done very commonly on the equine side of things. I think it can be very helpful in our canines. And we've actually started using musculoskeletal ultrasound more and more and more because it's minimally invasive. It doesn't necessarily always require sedation. We can actually look at the tissue architecture and put a grade on it. And we can use grading very similar to what they use in people, whether it's a grade 1, where there's a little bit of fiber disruption and disorganization versus a grade 2, which is there's a core lesion or a partial fiber disruption, maybe some haphazard arrangement, versus a grade 3 where there's complete tearing. But then we can also follow up with ultrasounds to see how the tissues are healing. However, and it's very, very user dependent because you can take a dog with a normal supraspinatus, and if you're off axis by 10 degrees even, that can create the appearance of a grade 1 lesion on ultrasound. We have to be very careful interpreting that. But then we can also utilize arthroscopy. But when we think about that with arthroscopy, as done here, we can evaluate for other conditions. We can visualize the biceps as seen right here. We can see all sort of those little tentacle-looking things. It's inflammation. The problem is that the supraspinatus is extra-articular, so we're not going to see that. But sometimes we can see a bulge pushing on the biceps to know that the supraspinatus is enlarged. So using arthroscopy for a supraspinatus strain, very challenging. My go-to there is musculoskeletal ultrasound, plus or minus an MRI if I need to. But for a bicep strain, musculoskeletal ultrasound can certainly be used. We can look at the changes to the tendon. We can see if there's fluid surrounding the tendon. But if I need to, I will scope the shoulder from both a diagnostic and therapeutic standpoint. And so, for example, this arthroscopic image here shows a really reddened and inflamed biceps, and we can see how much synovitis there is going on. This is more indicative of a biceps tendinopathy, where it's very unhappy, versus the lower image is a biceps tear. And you can see that there's not that much inflammation, but you can see that the fibers there are partially torn. And this was that dog I was actually showing you that had that loss of infill that we could keep going and going and going. This is a dog that needs a biceps release. The first arthroscopic video I show you, this dog does not need a biceps release. This dog can likely be treated without surgical intervention, which is why I think sometimes we jump to biceps releases a little too early. And so when we look at treatment recommendations, currently a lot of times the recommendations are based off of what did we get orthopedic exam-wise and what were our ultrasound findings. Now, if you don't have ultrasound, you really have to start thinking about your examination findings. And you can head down the pathway of appropriate management without an ultrasound if you have a high suspicion of what's going on. But we need to look at the dog's job. Is this a companion dog where they are set up for these injuries versus a canine athlete versus a working canine? Is it a grade 1, 2, or 3 based on ultrasound if we have that availability? And typically, there's going to have to be some degree of exercise restriction. Regardless, we need to take away the explosive activities. No running, no jumping, no playing, controlled leash walks. What gets owners here is the timeline. Because for these to heal, they're chronic in nature. For these to heal, it's likely going to take 8 to 12 weeks. The problem is, the dogs start looking like a rock star at about 6 weeks. And so then the owners ease up and they don't follow directions and they have a re-injury, and that sets the clock back to 0 again. So I tell every owner, patience is key here. You've got to stay patient and not get antsy. But if we were to just exercise restrict these dogs and do nothing more, those tissues are going to heal a little bit, but they're going to be tight and they're going to set themselves up for re-injury. So the other thing that we have to add in here is a formalized rehabilitation plan. So this is where you've got to commit to sending these clients to a rehabilitation therapist to work with these dogs. However, you can also do some things in-house, such as shockwave therapy. And then many times we'll do perilesional or intra-articular injections. Things that have been used in the past are biologics, so platelet products, stem cell products, or even steroids. However, I would likely not put steroids in the shoulder joint. If I'm doing injections, it's likely going to be of a biologic, and it's likely going to be a platelet product, which we'll talk about in a moment. But then you also have to treat other underlying conditions. Don't get tunnel vision saying, well, I listened to this guy talk, and he said that it's likely a shoulder injury, but the dog's got elbow pain. You can have a compensatory supraspinatus or biceps tendinopathy because they've altered their gait by unloading their elbow. So anytime you're working up a front limb lameness and you're convinced it's not the nails, the pads, the toes, or the neck, harp in and focus elbow and shoulder, and always image both to make sure. And I always image the contralateral for comparison's sake. So the previous treatments were simply for supraspinatus is, well, let's go in and let's excise that calcification. The problem here is that had variable success rates. The calcification tended to come back. And so you're also removing part of an active shoulder stabilizer. I am not a big fan of that. Now, sometimes there can be this huge little calcification that is very painful when you push on it, and you can split the fibers and it pops out. However, that is very rare. Most of the time, it's going to be embedded in there. You're not going to find it. So what is my go-to? What do I do? What I'm going to do is I'm going to do shockwave therapy, which is seen in this video here. I'm going to deliver about 700 to 1,000 pulses. And I'm going to do that for 3 treatments. So I'm going to do treatment 1, 2 weeks later, we're going to do treatment 2. 2 weeks later, we're going to do treatment 3. Now, this is usually set on the E6 setting, which equates to about 0.15 millijoules per millimeter squared. Now, after I shockwave them, then I'm going to do ultrasound-guided ACP or PRP injections. And this is an image of that same dog undergoing a ultrasound-guided PRP injection into the region of the supraspinatus. So it's perilesional. And then I'm going to send them home for a couple of weeks, and then they're going to start a rehabilitation program for 8 to 12 weeks. And they're going to come back to me 2 weeks after the first treatment. I'm going to shockwave them, inject them again. They're going to come back to me the 2 weeks after that. I'm going to shockwave them, and I'm going to inject them at that point. For biceps tendinopathies, many times the conservative aspect is very similar. Exercise restriction, again, 8 to 12 weeks, formalized rehabilitation therapy. We can also do intra-articular treatments such as hyaluronic acid or a steroid or a biologic. Again, my go-to is likely going to be a platelet product. But we can also do surgical interventions such as a biceps release. This is an arthroscopic biceps release. You know, I think at this point in the game, there's really no need to open up a shoulder to do a biceps release when we can do it arthroscopically. Some will talk about doing a tenodesis, which is where we release it and then reattach it a little bit further distally. If I had a performance dog, such as an agility dog or a racing dog of some sort, I would likely do a tenodesis rather than just a biceps release. But we did publish a few cases on biceps release and working canines, and those dogs were able to return to function. But again, for a biceps tendinopathy, my initial go-to, not a biceps tear, but a biceps tendinopathy, my go-to is the same protocol I use for a supraspinatus. 750 to 1,000 pulses with shockwave therapy, separated by 2 weeks for 3 treatments at the E6 setting. And then after I shockwave them, I'm going to do an intra-articular ACP or PRP injection, and then formal rehab for 8 to 12 weeks. And so this is an example of a dog getting an intra-articular injection. So a lot of times these dogs have both a supraspinatus and a biceps. And I'm differentiating bicep tendinopathy versus tear on examination, and then trying to differentiate tendinopathy of supraspinatus versus biceps on ultrasound. But more commonly, they'll have both. So if you don't have ultrasound and you have a high suspicion that they have both, then you could certainly do an intra-articular injection in your shockwave therapy. I think it would be very hard to do perilesional injections of the supraspinatus without ultrasound, but you can certainly shockwave the supraspinatus, shockwave the biceps, and intra-articularly inject for the biceps, put them in a rehab program for both, and likely be quite successful. So let's talk just a minute about shockwave therapy. You know, this is essentially the deliverance of high acoustic waves. And so it's generated by changes in pressure. And I think that probably the easiest way to think of this is lightning and thunder. Okay, you have lightning, which generates this impulse. It's the same thing with a shockwave. Something has to generate an impulse. So for example, with an electrohydraulic machine, there's a little spark plug. So once that spark plug fires, that generates the impulse. And so the thunder that follows, think about when your windows or walls shake. That's the impulse of that acoustic wave occurring. That's the shock wave. The problem here is that if your windows and walls shake, your neighbor's windows and walls shake. So it's not very focused. So what shockwave is doing is trying to create a focused impulse to direct that sound energy to the tissues for a biologic response. And so it's defined as a nonlinear wave of pressure and velocity generated outside the body. And this graph is important because what it shows is that a shock wave is characterized by a low tensile amplitude, but it very quickly gets to its peak pressure, like in nanoseconds. But then it very quickly drops off, so it doesn't last very long. But then what's important is there's this little negative dip, and that's important because that creates cavitation in the tissues, which increases cell permeability. It creates the generation of free radicals and the release of anti-inflammatories and growth factors. So what's important is when we're utilizing a shockwave unit, we need to know that that unit, it's been shown that it produces a true shockwave with that slight negative dip. Because if we don't get that, we are going to miss out on some of the biological effects of shockwave therapy. And so what is the mechanism of action? It's not fully known, but we have the release of that mechanical energy, okay? So that sound wave hits the tissues, and it's going to do a few things. It's going to increase the expression of cytokines and growth factors, which for a front limb soft tissue injury of the shoulder is excellent because a lot of times there's a poor healing response. So we can upregulate those resident tissues to start the healing process over, because sometimes it gets a bit dull since these are chronic. It helps decrease inflammatory mediators. It helps promote neovascularization, which is also great because if we're dealing with an area of poor blood supply, upregulating vascularity is great to bring in further reparative cells and improving those cells' working ability that are there to proliferate and heal, and then also upregulate resident stem cells to further aid in the healing response. And then it can also have an analgesic effect through the increase of serotonin. And so simply using shockwave alone can have an effect on comfort. And in fact, it can have a long-lasting effect. The studies from osteoarthritis show us that with a shockwave series, we can see effects, improvement of limb usage on peak vertical force up to about 90 days post-treatment. So it's very long-lived treatment. And so following an initial shockwave treatment, I tell owners they may see no change. They may see slight improvement due to the immediate analgesic effect, or they may see some slight worsening of lameness due to a little bit of discomfort, which is usually resolved within about 24 to 48 hours. So the biological effects that are going on is that primary effect is the generation of those forces and the things we just talked about: the neovascularization, release of anti-inflammatories, upregulation of growth factors, increased proliferation of cells, upregulation of stem cells, as well as the analgesic effect. But we also have a secondary effect through that slight negative dip where we get cavitation and the release of free radicals and other chemical responses, which can be a good thing. But then we also see some compression and tension that occurs, because as that sound wave is being delivered, that's going to compress and cause tensile forces to those tissues, which is known as mechanotransduction. We know that tendons and ligaments respond to healing by mechanotransduction. Putting a little bit of stress or stimulus to them is going to create biological responses, which I think is fabulous when it comes to tendinopathies. And so if we look at what's going on and what our thought process here, because we also need to have some scientific evidence of what we're doing can be effective. And so what with tendon and ligament injuries, we're hoping to improve the ability of the tissues to heal through neovascularization and release of growth factors. And so there's been some rat model studies looking at the induction of Achilles tendinopathies and what it looks like post-shockwave treatment. And they found the release of things like tumor growth factor beta 1 and insulin-like growth factor 1, which are important for cell and tissue healing. But we also know that using things like PRP also create the release of these things. And so if we can upregulate or stimulate the release of these by combining shockwave and our platelet products, I think that's a positive. In a rabbit model of patellar tendinopathies, they found that it not only helped with healing, but it also increased the tensile strength, which I said earlier with a tendinopathy, many a times the strength before failure decreases because the elasticity of those tendons are decreased. And so I think that can also be helpful. Now, interestingly enough, a lot of what we recommend for supraspinatus or biceps tendinopathies is based purely on speculation because the disease process itself is not very well known. And so, interestingly enough, we do have a couple of studies looking at shockwave therapy for these tendinopathies, which actually is more evidence than some of the things we currently recommend, like rehabilitation therapy. And so, for example, this is one study. Now, it is a retrospective study, so it's a level 4 study with a high risk of bias, but this had 15 dogs that failed the conservative exercise restriction and rehab. I'm sorry, exercise restriction with no rehab. So they underwent shockwave therapy. They had 3 treatments, similar to what I do. They were spaced at 3 to 4 weeks apart of 750 pulses. I don't know what the energy setting was. They did not undergo a rehab program, but they found that at 4 weeks post-treatment, all of them had, about, I would say almost a little over half of them had improvement. And then at long-term follow-up, all of them had resolution of the lameness. And then at long-term follow-up, what we're seeing is, and this is well over 2 years, about 64% of them had improved or resolved lameness. And so, this goes along, interestingly enough, with the exercise restriction and rehabilitation approach with no shockwave, no biologic. We see about 80 some odd % of these dogs respond. if we can add in shockwave and our biologics to therapy, we can hopefully increase that improvement percentage. The other study was also nice. Again, a retrospective study, so level 4 with high risk of bias. This had about 30 dogs in it, so 29 to be exact. These dogs underwent 3 sessions, 3 weeks apart, and then they also had therapeutic exercises done. Now, it wasn't reported on what the energy level was or the number of pulses they received, but in owner assessment, and of course there's flaws with that, but in owner assessment, they found about 85% success, which is actually a bit higher than what we traditionally see with just exercise restriction and formal rehabilitation therapy. And the average recovery time here, remember, I said this is a very long recovery period. Their average recovery time was about 16 weeks. I tell owners, we're on the band for about 12 weeks at least, and then probably about 4 weeks of slow return to normal activity. So patience is key. Other things from a rehab therapy, though, is going to be the release of trigger points and massage and stretching. So a lot of manual therapies initially, and as they get more comfortable, we can add in modalities like laser therapy, but the problem there is it's very short-lived, so we can use that at sessions. We can use therapeutic ultrasounds to heat up the tissues to aid in stretching. And then we can also use the underwater treadmill. However, for a front limb lameness, especially tendinopathy, they have to be comfortable on palpation before we put them in the water. If we get them in the water prematurely, we're going to exacerbate the condition. And I see this happen week after week after week in patients going in the underwater treadmill too soon. We have to understand what we're doing and what our goals are. We're going to then start our isometric exercises in terms of balance and early strengthening and move to end-stage strengthening in the latter part, like 8 to 12 weeks later of eccentric concentric conditioning. What do we expect to see as prognosis? Well, the problem is there's not a lot reported in the literature. Now, there was a couple of studies that have come out. One is looked at these dogs that were diagnosed as grade 1 or grade 2 or first-time offenders. They saw that about 42% of these dogs responded to just treatment of exercise restriction and rehab. So they developed the 50-50 rule. But then they found that dogs with grade 2 plus strains or dogs that went through exercise restriction rehab didn't do well and then underwent the addition of intralesional injections of stem cell and PRP had about an 82% return to function. Be very cautious interpreting this data. It was very much full of biasness, and it was also funded by a company. So they had a vested interest in seeing that these dogs would do better with the addition of an injection of something. What we know in the retrospective study, which wasn't funded by a company, that with shockwave therapy and therapeutic exercises, we see about an 85% return. And that's a much cheaper option than utilizing stem cell therapy for these. So I don't necessarily think stem cell therapy is the best for these. And in fact, I don't use stem cell therapy with these unless I'm at the end of the rope and we're reaching for straws. But you remember, you got to also treat concurrent conditions. And so what I would tell you is, at least in my hands, diagnosing these and then 8 to 12 weeks of a formalized rehabilitation program, 3 treatments, shockwave therapy, and either intralesional or perilesional or intraarticular PRP, I would say about 85 to 87% of these dogs get back to normal activity. The killer to that is the owner not putting in enough time and being patient. All right. We're going to talk a little bit about medial shoulder syndrome because I want to introduce this concept to you. I hope that makes a lot of sense on supraspinatus and biceps. We'll have some time, hopefully afterwards, for some discussion. But a medial shoulder syndrome is an open diagnosis of a unilateral forelimb lameness, or could be bilateral. Again, they tend to be worse after exercise. They tend to be non-responsive to NSAIDs and exercise restriction. And then some of them may have no lameness at all, because we originally started recognizing this in our sporting dogs, where they might have a shortened stride length. They might be knuckling bars, so they're not jumping as high. They're pulling up or refusing weaves, or they're taking these wide sweeping turns instead of nice tight cuts. And so the problem here is, if you look at the history is going to be almost identical to a supraspinatus or biceps tendinopathy. So based on the history alone, you're not going to be able to tell. And so if we look at the structures of the medial shoulder, there's our medial glenohumeral ligament, which is a passive stabilizer. We have our joint capsule, and then we have our subscapularis tendon, which originates on the subscapular fossa. It inserts on the minor tubercle, and it aids in adduction and extending the shoulder, as well as maintaining flexion. And where it runs is, it runs just between the biceps and the MGL. So if we look at this arthroscopic video, this is going to be normal structures in the cranial compartment of the shoulder. So our humeral head, our glenoid cavity coming in the near field, that shiny white structure is going to be our medial glenohumeral ligament. In the backfield coming in obliquely right there, that's our subscapularis. There's our biceps tendon just to the right of that. So biceps is right here that we're looking at. Joint capsule in the back. Then we've got our subscapularis, and in that very near field is our medial glenohumeral ligament. So that's normal. So let's ask ourselves, does this occur commonly or rarely? It's rarely diagnosed, but it likely occurs more commonly. And we can see things like MGL tears, we can see things like subscapularis tears. And in fact, the medial glenohumeral ligament was stated by Dr. Bardet, a French surgeon way back in the late 90s, that the MGL plays a role in shoulder stability, and that almost 70% of dogs with chronic forelimb lamenesses have pathology of the MGL. And the MGL pathology is the most common form of shoulder instability. But what's the clinical significance of these structures? The problem is we really have no idea. This was a study done in 2013 in VCOT, where they actually transected the cranial arm of the medial glenohumeral ligament in normal dogs. They found that transecting that, because the medial glenohumeral ligament is actually like a V, they transected one of those arms. They found that it caused some inflammation in the shoulder, but it did not affect stability of the shoulder. And so they theorized that maybe with repetitive motion over time, it could result in shoulder instability. And so then we have to ask ourselves, okay, well, what structures need to be damaged and to what degree? Meaning we can see fraying of the MGL, we can see fraying of the subscapularis. We can see tearing of the MGL, but fraying of the subscapularis. We can see fraying of the MGL, tearing of the subscapularis. We can see tearing of both structures. The question is what structures have to be damaged to produce clinical signs or cause a clinical issue? And realistically, there's no one size fits all. But we do see this more and more diagnosed in agility dogs. I think it makes sense because they're putting a lot of rotational torque on that shoulder and likely stretching a lot of these structures because their conditioning is not good from a stability standpoint and muscle mass standpoint. And so here's an example of a dog that's doing some backyard training and agility, and this dog was doing quite well. You know, this dog's jumping, this dog's taking nice tight turns, timing of the dog's ability to compete wasn't really altered. But interestingly enough, if we look inside this dog's shoulder, this exact dog that's doing really well, notice that the upper shiny is the glenoid, the bottom shiny is the humeral head, coming in obliquely, in an oblique nature. That's going to be our subscapularis, which looks good, but there's no MGL. The MGL is completely gone. So this dog has no medial glenohumeral ligament, but is completely sound and fine. But I actually had a dog just yesterday that is extremely lame that was diagnosed with an MGL tear based on an MRI and did really well for conservative treatment and then re-injured itself. And so if I scope this dog on Friday, which we plan to do, and there's no MGL, why is it that this dog in the video I'm showing you here is completely sound, but the dog that I may scope on Friday that has no MGL is like severely lame? We don't know. We don't know. But sometimes they can have no lameness. So this dog here that has what I would consider a grade 3 to 4 out of 5 front limb lameness. What we tend to see is pain on shoulder extension abduction. I rely on pain. I don't care about abduction angles. It was said that the normal abduction angle is roughly about 30 degrees. And if a dog has medial shoulder syndrome, it's going to be greater than about 50 degrees. But you got to compare it to the contralateral, because in racing sled dogs, they can go out to 70 degrees and be completely normal after long runs. And so we want to extend the shoulder about 45 degrees. We want to push the scapula. So I push the acromion process onto the body wall, and I'm simply trying to abduct the shoulder. I'm not pulling the scapula away from the body wall. But we know that abduction angles are not very good. They're not repeatable, and they have poor accuracy. That was shown in this study that was initially presented at abstract that went on to be published, that found that there really wasn't a big a difference between dogs that had all the intact structures versus dogs that had them all transected. But then comparing it to fluoroscopy, there was poor accuracy and there was poor repeatability. So I don't rely on abduction angles. I rely on discomfort. But diagnostics are tricky. radiographs aren't going to be very helpful. MRI, some will do this. You can see MGL tears. Subscapularis tears can also be diagnosed there, but sometimes it can be a little bit challenging to truly know what's going on there. Musculoskeletal ultrasound, some will go here as well. The sports med people love this. The radiologists say you're crazy because you can never get the probe perpendicular to the structure. So they say you can't actually image the medial shoulder very well with an ultrasound probe. And then arthroscopy would be one way to go, which is a direct ability to look at it. And I think right now, to truly know what structures are damaged, it's either going to be an MRI arthrogram, or arthroscopy. And so, for example, on scoping, we can see this image where there's some fraying of the MGL. It looks a little ratty. There's a little partial tear. It's not that bad. It's intact, but it's frayed. Versus this video where this dog has a torn MGL. So same disease condition, 2 different degrees of severity. The problem is there's not that much correlation between trying to figure out how severely damaged the structures are based simply just on palpation. I think we really need to lay eyes on it, which is what makes this disease condition very, very challenging. As far as treatment goes, it's very controversial and debatable. Should we treat them surgically or should we treat them conservatively? And if we treat them surgically, what should we do? There's what's called thermal capsuloropathy, where we can use a radiofrequency probe. We can use some sort of reconstruction with a prosthetic. We could do a biceps transposition. We could do an imbrication of the subscapularis. And then there was a study that came out that found that surgical reconstruction has a higher likelihood of success compared to non-surgical management. However, we still don't know how to truly define what dogs would benefit from surgery versus what dogs would benefit from conservative management. And I do think the dogs that have just mild fraying likely need conservative management. The vast majority of these dogs need conservative management. A very small population actually needs surgical management. But the problem is many times we have to do arthroscopy to look from a diagnostic standpoint. So here's my approach to these dogs. Unless it's very severe, I'm going to put them in hobbles. That's that upper left image. So they can't abduct, and they're going to go into that for about 4 to 6 weeks. We're going to enroll them into a formalized rehabilitation therapy for roughly about 12 weeks. I'm going to do shockwave therapy, and I'm going to do intra-articular biologics, very similar to the way I treat my supraspinatus and my biceps. So for my shockwave, we're going to really focus on the insertion point on the proximal humerus medially in the glenoid cavity. I'm going to get them in. I'm going to do a total of 3 treatments separated by 2 weeks at 750 to 1,000 pulses on the E6 setting. So again, that's about 0.15 millijoules per millimeter squared. And then at 4 weeks, if they're improving in comfort, we're going to get them out of the hobbles. They're going to continue rehab, and they're going to start their strengthening exercises. And so every time I shockwave, I'm going to shockwave, and then I'm going to do an intra-articular injection of PRP. And so we actually have a paper that's undergoing review right now where myself and 2 other surgeons looked at what are some of the incidence factors, because we found that there was current evidence lacking on the diagnostics, recommendations, treatment options, and rehab plans and overall outcome on medial shoulder syndrome. And essentially, without going into fine details, what we found is that most agree it's due to chronic repetitive strain, not acute injuries, but some of them can sustain acute injuries. The currently available diagnostics are of questionable accuracy because a lot of people rely on shoulder abduction. That most individuals are going to rely heavily on rehabilitation first over surgery, and I fully agree with that. And that we would only rely on surgery for cases that are non-responsive to a true conservative approach. And if we do rely on surgery, it's typically through a prosthetic ligamentous reconstruction, which traditionally has been very invasive from an open approach. And so there are a couple of individuals that are starting to fine-tune a fully arthroscopic approach, which hopefully is what we'll be able to do with this dog that I'll be seeing in the near future. So in summary, we want to eliminate the term soft tissue injury. We want to try to find the actual tissue injured, and it could be more than one. So you got to utilize diagnostics. Your hands and your examination are number one, but then think about radiographs and then the pros and cons of things like musculoskeletal ultrasound, MRI, and arthroscopy. Because I think once we fine tune what's damaged and what degree it's damaged, we can improve our treatment and rehabilitation plans. And then for non-responsive forelimb lameness, is if you're treating it as a typical soft tissue injury and it's not getting better, think about, could I be dealing with a supraspinatus tendinopathy, a biceps tendinopathy, or medial shoulder syndrome? And then I do think that in addition to exercise restriction and formalized rehabilitation plans, shockwave therapy and biologics such as platelet products are my go-to. And I do 3 treatments separated by 2 weeks each. And then there's the lack of typical inflammatory responses. Remember, we talked about that lack of blood flow and the lack of the typical inflammatory response we see for supraspinatus and biceps tendinopathies, which is why NSAIDs are effective initially, become less effective, and are not completely effective. And unfortunately, with what we have out there now, we need more controlled objective data for these disease conditions is to then truly diagnose and then also lay out treatment plans based on the degree of severity and what structures are damaged. And so with that being said, I just want to leave this information here for just a moment. If you are a social media fan, here's my Instagram and Facebook profiles. If you have a question, we don't happen to get to it, here's my email address. Feel free to email me at any point. I will get back to you. It may just take me a few days to get through, so don't panic.